Right now, roughly 1 in 4 seniors with dementia is taking a medication that is actively working against the drug prescribed to protect their memory. At the same time, from the same doctor, I have reviewed thousands of medication lists in geriatric medicine, and the same devastating pattern appears over and over. The memory drug in the morning, and 2 or 3 other prescriptions in that same bag that are quietly canceling it out. Today I'm going to show you exactly which drugs are doing this, why your doctor may not realize it, and the 5 specific questions you can bring to your next appointment to change it. I'm Dr. Helen Carter. This channel is dedicated to translating current medical research into practical, actionable information for adults over 60 and the families caring for them. If you haven't subscribed yet, please do that now, because what I am covering today is one of the most consequential medication issues I have encountered in this field, and I want to be clear about something before we begin. The American Geriatric Society maintains an official list called the Beers Criteria, a regularly updated, medically reviewed list of medications considered potentially inappropriate for older adults. Several of the drugs I am covering today are on that list. This is not fringe medicine. This is mainstream geriatrics. It simply has not yet reached the mainstream conversation. To understand what is happening in that pill organizer, you need to understand one thing about how memory works inside a brain with Alzheimer's disease. I am going to explain it simply, and once you see it, everything else will make sense immediately. Think of a chemical called acetylcholine as a bank account. Your brain uses it to run memory. Every time you recognize a face, recall a name, or hold a thought from one moment to the next, acetylcholine is the currency. In a healthy brain at 65, that account is lower than it was at 35. Normal aging depletes it gradually, but in a brain with Alzheimer's disease, that account has already been robbed. The neurons that produce acetylcholine are among the first destroyed by the disease. What remains is a fraction of what was there before. Now, the memory medication your doctor prescribes, Donepezil, sold as Aricept, works by putting a lock on what remains. It slows the rate at which the brain spends its last reserves. Not a deposit, a lock. Here is the problem. There is an entire class of common medications called anticholinergics. They work in the directly opposite direction. Instead of locking the account, they remove the lock and make withdrawals, and they are being prescribed to dementia patients every single day. A 2023 study from the University of Pittsburgh followed 1,959 seniors and found that anticholinergic use was independently associated with cognitive impairment, regardless of any other factor. And in a brain that already has Alzheimer's disease, where the reserves are already nearly gone, every unit lost to an anticholinergic drug is a larger percentage of what remains. The most common drug I find opposing the dementia medication is one you may know as ditropam, generic name Oxybutynin, prescribed for one of the most common complaints among adults over 65: overactive bladder, urgency, incontinence. It works. It reduces urgency quickly. And because it works, most people and most doctors never question it. That is the problem. Oxybutynin is one of the most potent anticholinergic drugs in common clinical use. And unlike many medications in its class, it crosses the blood-brain barrier aggressively. It does not just work on the bladder. It reaches the brain, the memory pathways, the same ones Alzheimer's disease has already compromised. A landmark study published in JAMA Internal Medicine followed 3,434 adults aged 65 and older for over 7 years. Those with the highest cumulative anticholinergic use had a 54% increased risk of developing dementia compared to non-users. A follow-up study in 2019, same journal, 58,769 dementia patients, confirmed the findings specifically for bladder antimuscarinics, including oxybutynin. And brain imaging studies have documented this directly. Measurable reductions in metabolic activity in memory-associated regions of the brain. The brain is visibly less active. Margaret was 77. Mild Alzheimer's, managed on Donepezil. Her neurologist was cautiously optimistic about her rate of decline. Then a urologist, managing her bladder separately, prescribed oxybutynin. Over 18 months, her family watched her decline faster than the disease trajectory predicted. Steeper. Faster than it should have been. A new geriatrician reviewed her complete medication list, flagged the oxybutynin immediately, switched her, carefully, with supervision, to mirabegron, brand name Mirbatric. Same bladder condition, different mechanism, no anticholinergic risk. 6 months later, her rate of cognitive decline measurably stabilized. Her daughter told me it felt like finding out there was something they could actually do. And oxybutynin is not alone. I need to name the rest of the family. Amitriptyline, brand name Elavil. Nortriptyline, tricyclic antidepressants prescribed for nerve pain and sleep. Diphenhydramine, sold as Benadryl, and the active ingredient in any sleep aid with PM in the name. Zequil, Unisom, Tylenol PM. If your loved one with dementia takes any of these, for any reason, they are directly working against the drug prescribed to protect their memory. Comment below right now. Is your loved one or parent currently taking a bladder medication or a sleep aid with PM in the name alongside their Alzheimer's prescription? I want to know how many families are dealing with this exact situation. And if you haven't subscribed yet, please do it right now, because I release new research-based content every week specifically for adults over 60 and the people who care for them. You don't want to miss what I'm covering next week. You just saw an FDA black box warning. That is the most serious safety designation the FDA can place on a drug. It means the agency has found sufficient evidence that a medication causes death, and that every prescribing doctor must be formally notified. The box you just saw applies to antipsychotic drugs prescribed to elderly dementia patients. The brand names are Risperdal, that's risperidone, Seroquel, quetiapine, Zyprexa, olanzapine, Haldol, haloperidol, developed for schizophrenia and bipolar disorder, not approved for dementia. The FDA reviewed 17 separate controlled trials, 17 studies, and the finding was consistent across all of them. In the placebo groups, 2.6% of dementia patients died. In the antipsychotic groups, 4.5%. That is a 1.7 times increased risk of death. The causes: congestive heart failure, sudden cardiac death, and pneumonia. Pneumonia, which is separately the most common cause of death in people with advanced dementia. The black box warning was issued in 2005, extended to all antipsychotics in 2008, and a 2024 analysis of Medicare data found that roughly 1 in 4 seniors with dementia is still being prescribed these drugs today. Dementia causes behavioral symptoms: agitation, aggression, wandering at night. These are genuinely difficult to manage, especially in a memory care facility with limited staff and no other FDA-approved behavioral treatment. Antipsychotics sedate quickly. In the short term, they appear to solve an immediate problem. But here's what happens beneath the sedation. They do not just sedate. They slow movement. They blunt cognition. They suppress the parts of a person that are still present, still accessible, still recognizable. A person who was walking the hallway last week, who still recognized faces, who still responded to their name, can become unresponsive within days of starting these medications. The family notices. They ask what happened. They are told the disease has progressed. Sometimes that is true, and sometimes it is the medication. Robert was 81, moderate Alzheimer's at a memory care facility. He became agitated at night, wandering, distressed. His care team prescribed quetiapine, Seroquel, at a low dose. Within 2 weeks, his family noticed he no longer recognized his wife during daily visits. He sat slumped. He stopped eating independently. A reviewing physician concluded the changes were medication-driven, not disease progression. The quetiapine was tapered, carefully, over 3 weeks, and replaced with structured activities, consistent lighting, and a fixed sleep-wake routine. Robert recognized his wife again within 10 days. Not cured, but the family got months back they had been told they had already lost. The recommended first-line treatment for behavioral symptoms in dementia is non-pharmacological. Structured activities tailored to the person's history. Personalized music playlists. consistent daily routines, bright light therapy. These approaches reduce agitation to a degree comparable to medication, without a black box warning. Now, I need you to stay with me for the third category, because this one is different from the first two. This one involves the dementia drug itself, the one that is supposed to be protecting your loved one's memory, and what the research tells us about what it can and cannot actually do. This is the part most families are never clearly told. Donepezil, Aricept, is not itself harmful. I want to be direct about that. For the right patient, it is the correct, evidence-based standard of care. I am not telling you to stop it. What I am telling you is what it actually does. Because most families I speak with have a different understanding of it than the evidence supports. The Cochrane Review, 30 randomized controlled trials, 8,257 patients, found that Donepezil provides a modest benefit in roughly half of the people who take it, for an average of 6 to 12 months. It does not stop the disease. It does not reverse the disease. It slows, slightly, temporarily, the rate of symptomatic worsening. For some families, those months are deeply meaningful. I want to honor that. But here is the arithmetic that matters. If Donepezil's benefit is modest and temporary, and your loved one is simultaneously taking 2 or 3 drugs from the anticholinergic family, then you are not just receiving partial benefit from one drug. You are actively canceling the partial benefit you were counting on. Researchers call this Anticholinergic Burden, the cumulative load across every drug a person takes, not just one drug, but the total. A 2023 analysis in Frontiers in Aging Neuroscience found that higher anticholinergic burden is associated with accelerated cognitive decline and measurable brain atrophy across the full Alzheimer's spectrum, from normal cognition all the way through advanced dementia. Brain MRI studies show this directly. Actual physical shrinkage in memory-associated regions, visible, measurable. A person taking Donepezil alongside 2 or 3 anticholinergic drugs may be experiencing net zero benefit from the dementia treatment, or worse, and almost no one is calculating that total. The neurologist sees the memory, the urologist sees the bladder, the psychiatrist or nursing home physician sees the behavioral symptoms. 3 specialists, 3 prescriptions, 3 separate lists that are rarely reviewed as a single system. Each individual prescription may seem entirely reasonable in isolation. The problem is that the brain with Alzheimer's disease does not experience them in isolation. It experiences the total burden, the combined effect. The net result, which no single doctor in a 15-minute appointment is consistently calculating. This is not negligence. This is not malice. This is the architecture of modern specialty medicine colliding with the complexity of a disease that affects the whole person, not just one organ, not just one specialist's jurisdiction. You now have information that allows you to change that. Here is exactly what to do with it. Here is exactly what you should do with everything you have just learned. Step 1. Write down every medication your loved one currently takes, prescription and over-the-counter. Include Benadryl. Include any sleep aid with PM in the name. Include the bladder medication. Every pill goes on the list. Step 2. Search the phrase anticholinergic drug score alongside each medication name. This returns a cognitive risk rating. Any drug rated moderate or high warrants a conversation with the physician managing the dementia, not just the doctor who prescribed it. Step 3. Bring the complete list to the next appointment and ask 3 specific questions. Ask, has the combined anticholinergic burden been reviewed against the dementia treatment? Ask, has anyone performed a medication review across all prescribers? And ask, is there a safer alternative to this specific drug without anticholinergic effects? Step 4. If your loved one is in a memory care facility and is prescribed an antipsychotic, ask directly what non-pharmacological interventions were attempted first. Step 5. Request a formal geriatric medication review if your loved one sees more than 2 specialists. Ask for a review using the Beers criteria as the standard. A critical safety note. Do not stop or change any prescription medication without speaking to the prescribing physician first. Abrupt discontinuation can cause serious withdrawal effects. Every change must be supervised, gradual, and monitored. Here is what the evidence tells us in one sentence. Many cases of what appears to be rapid dementia progression are actually, at least in part, medication-driven cognitive impairment. That distinction matters more than almost anything else I can tell you, because medication-driven impairment is modifiable. The disease is not. When contributing drugs are identified and addressed under physician guidance, families consistently report that their loved one is more present, more responsive, more themselves, not cured, but more themselves. And in a disease that only moves in one direction, more themselves is everything. You deserve to know this, and now you do. Please subscribe if you haven't already, because next week I am covering the 5 nutrient deficiencies directly linked to accelerated cognitive decline in seniors, including one being caused by a medication that tens of millions of people take every day for a completely unrelated condition.